Okay, it's recording, and this will be put into the digital toolbox for any of your case managers to listen to later. So let's see. All right, so next, this is our agenda, and thank you, Rydell. And welcome, everyone. We greatly appreciate all of you coming in and listening and your dedication to all of our members and all of your hard work. Access does appreciate it, and we do respect and our partnership with you. So thank you on that. And let's see. It won't move. There. How it missed something. Well, one of the screens that we have is to ask everyone to please mute yourself unless you need to speak. Then you can unmute yourself to try to keep distractions to a minimum and just sit back and absorb. And again, just we appreciate you being here. And I'm going to go ahead and turn off my camera because it does slow things down on our side. So. All right. And the first thing that we have is we are going to have an icebreaker this morning. So that will be presented by Bandana Chetty, Amber Heard, and myself. And due to Valentine's Day being yesterday, this icebreaker will be about Valentine's Day. All right, and a few tips right up front is, so Amber and Bandana are going to keep track. We will be asking some questions. So please put in the chat your answer. The first person to answer the right question, to provide the first answer. And then at the end, we will present who the winners are. We will be sending out a gift card to 3 people. So if you could sit back and enjoy and be prepared to put in the chat your answer. All right, here we go. So Valentine's, here comes the first question. Are you ready? Here we go. So when did Valentine's Day become a U.S. recognized holiday? And we're not necessarily looking for the year but the decade. Bandana, Amber, anybody answering? I cannot see on that side.
No.
Yes, Jolie's got 1849.
Okay. All right. So we have an answer for that. And guess what? She is right. It's the 1840s. So very good. Okay, next. What is the most popular Valentine's Day candy? Anybody? Bandana and Amber, you watching? What's the most popular Valentine's Day candy?
Christina's the first one, I believe, that answered chocolate.
Okay, chocolate. Anybody else?
Lakeisha's got sweetheart. City's got chocolate.
Okay. All right.
Jolie,
and the correct answer.
Conversation.
Okay, who said that?
Jolie.
Okay, here we go. Here's the answer. Conversation hearts. You're absolutely correct. All right, next. And I'm going to turn it over to Bandana.
What is the most popular flower given on Valentine's Day?
Lakeisha got it. Rose.
Okay, and the answer is the red rose. Next.
What do the M stands for in M&M candies?
Anybody?
Jolie,
And what was the answer?
Jolie put Mars and Murray.
And the answer is, the actual official answer is Mars and Murray. That's correct. If you said melt in your mouth, we were going to give that to you too, because that's a very popular slogan. All right,
Lakeisha
next.
just
This
answered.
is
Melt in mouth too.
okay. And Amber, you're up.
Okay, what profession received the most Valentine's Day cards?
Anybody?
Christina did. Teachers.
Frida.
Oh, Frida. Frida was the first one.
Okay. Who was the first one?
Frida.
Frida.
All right. So here we go.
What is the meaning of X and O in the XOXO?
It's anybody? No?
Actually, Lakeisha has hugs and kids.
Nobody knows?
Lakeisha. She
Oh,
chatted.
Lakeisha. Oh, okay. Yep. Hugs and kisses. That's what it stands for, right? So, all right. Thank you, everyone, for participating in our icebreaker. We didn't have a lot of time, but we wanted to make sure that you all got, and ladies, keep track of who won, and we'll provide answers at the end. Okay, I'm going to go ahead and turn it over to Rachel.
Yeah, good morning, everybody. We always want to try to start off and get everybody relaxed. And I know there's people that come in that is new to Tribal ALTCS or externally and also internally. We have some new staff that we're going to introduce because now the rest of the meeting is basically going to be focused on business. And usually we get kind of antsy or we want to step away or whatever. So it's just like we start with something relaxing and kind of get our brains to working and start to focus on what we're going to present on today. There's quite a bit of things that we're going to bring up that is very important to the Tribal ALTCS program, very important for leadership on your end. I'm assuming everyone on here, I believe there's about 20 people on here altogether, but it's for leadership to learn, leadership to know, and to be aware of the changes that are happening within the program that you all are actually overseeing on the tribal side. I do see a lot of phone numbers coming. I see it coming on. I see also new people. For the new people, if you could please put in the chat who you are and where you're joining from, what office you're representing, please do so. We want to make sure that there is someone accounted for from each office. And we encourage the participants also to share the presentation maybe at your team meetings or your quarterly meetings or whatever meetings that you have, or use it as a training guide. Because a lot of these things that we present on, we do track and monitor it at the state level. And as you'll see in some of the presentation, the purpose of why we have these presentations, and we were looking at some yesterday, and I asked my team, why are we presenting on this again? Because we've addressed some of these already in previous trainings, and they are finding it in as some of an issue that continues to come up on the requests that they are receiving. So that is the reason why we really have to go back and make sure that we're covering these bases. So we have a tracking mechanism to show that we are providing training to you all. And we're hoping that leadership is sharing this information with their case managers, because most case managers do not attend. Some of the programs don't want the case managers to attend. They want only leadership to attend, to kind of minimize and all the questions, because we do have a short length of time that we present. And we do have a lot of information to share. So, but at any time, if you feel like, okay, this is a topic that I want to train on, and then you train on it, utilize our tools, our training tools here, you take it back and your team still doesn't understand, or they want us to elaborate more, you can always request for my team to present on that individual topic. And they can do a virtual meeting with your team and on any of these topics that we present on. But I do, after looking at some of the records of what we're training on, I do see that some of these have already been conducted in previous trainings that we have. So please, leadership, let your case managers know they can always go on to the Tribal ALTCS digital toolbox and obtain these trainings on their own. They can do it as a computer-based training for them if you need to, or if you have a new person coming in, you can utilize some of these training resources for them. And it kind of does help them also to learn on their own. And that's pretty much what my team does. A lot of things that they do, we give them the policies and procedures, and we allow them to take their time to learn these policies and procedures, because all in all, it is from what stems from the federal requirements that we have to implement within our programs. So I'll go ahead and kind of give you guys an idea of how it looks like, because I know there's quite a bit of new people here, how we work internally and to review some of these policies and the current policies that are open now, which the tribal stakeholders have an opportunity to respond to some of these policies as they're being at the meetings that are presented. There's usually a public comment period where tribes can have their leadership can come in and review these policies and make comments on these policies too. So I don't know what level you all are at to where you can speak with those people who respond on your end and to review these policies on your end, have an opportunity to do that. And it just is very important because every tribal community is very, very different. And I want to ensure that, you all are speaking on the services within those communities as it's happening. Because at the state level, they don't know, they don't live in those areas, they don't know the challenges and the barriers that you all face. So it's really good to, be part of these policy meetings or updates. So we can go ahead and go to the next slide. I'm going to go ahead and turn my camera off too, because it kind of does affect the bandwidth. And if you can't hear me, please let me know, because sometimes I have issues with my mic. So alrighty. So during our policy update period, usually it starts in January. Our policy work group team, which is in DHCS, Division of Healthcare Services, they used to be DHCM, Division of Healthcare Management, but they're now DHCS. They typically look at the policy work group team, they open up the policies, and they'll give an opportunity for internal divisions or departments to actually look at divisions, departments, units, whatever it may be. They'll give them an opportunity to review these policies, and there could be revisions that was in a parking lot that needed to be maybe somewhere within the year. The tribe may have identified something, or a contractor may have identified something and said, we want to change these, or it could have been there was some changes in the rules and regulations, so things were put in a parking lot. So when the policy opened up again, it gives the work group an opportunity to review these policies, and the access leads these work groups internally, and then they assign it to the subject matter experts within the agency. So if it's something typically related to American Indian Health Plan, they will all be assigned to Division of Fee-for-Service Management, whether it's AIHP, THP, or Tribal ALTCS or TRIBA. They'll send it over to DFSM, which is the unit that we are housed in. They'll allow them to go ahead and, you know, you all look at it. What have you heard throughout the year? What are some challenges that you all have heard? Please give us some feedback, and you know, trying to align to stay aligned with the federal requirements. So that's how the policies open up at the beginning of the year. And typically these policies any changes that are made will go into effect October 1st, that year, within the year that the policy is opened up. Next slide. Ooh, okay. If you could just click on all of it. Yeah, get everything up in there. Okay, so within this policy, you know, we do cover a lot of different policies. There are about 256 policies, and this doesn't just apply to tribal ALTCS. It's for when the policy work group opens these policies, they are actually opening up for all of the programs that are overseen, whether it's long-term care, acute care services, behavioral health services, and then it does outline, you know, which program that these policies are affecting. In the fee-for-service portion, again, within DFSM, we do different areas, American Indian Health Plan. We also do the THP population at the TRIBAs, and of course the tribal ALTCS. Those policies do affect all of us, and we need to make sure that we're all part of these discussions. And it's 256 policies. That's a lot of policies, and everyone kind of has their subject matter expert in certain areas. And the purpose of the AMPM policy is really to provide information not only to the tribal ALTCS on the fee-for-service side for tribal ALTCS for us, but also on the managed care, and also on the fee-for-service side. We include a lot of the providers in the policies, just to let them know that they have a responsibility to ensure and implement these policies too. So as I mentioned before, these manuals or the policies really has to align with the federal and state regulations and other agency manuals, just like CDD has their own manuals. You know, we have to make sure, or health plans have their own manuals, and they all have to be aligned as it is applicable to the contract. As for the tribe, it would be aligned with the IGAs. Next slide. So this is the phase of our policy, how it rolls out. Once there's a recommendation that comes up, not only from the rules or the regulations, we need to ensure how we implement that and how we're going to regulate it at the state level. How are we going to implement it? As for the tribal ALTCS program, the tribes hold the IGA, you know, for long-term care services. But all in general, we are all within DFSM, we are a part of that collaboration and coordination and ensuring that these members receive services, not just long-term care services, but also acute care services. So there will be some further on in the presentation, the team members are going to be talking about those services and letting you all know that everything that they present on here is part of the policy, what is required. It's not something that the state only requires. They really have to be aligned with the federal requirements based on the concerns, the issues, and to you know, help with the fraud, waste, and abuse, you know, those kind of things, and ensuring that our members are getting the services that they need. So there's the policy phase that it goes through a lot of review. The work group phases, which I said the subject matter experts, they review it, they make sure that, you know, for us, whatever is assigned to DFSM for tribal ALTCS, they'll have us review it, the policies, and we'll, you know, provide recommendations. We'll also provide, okay, this language needs to be revised to be able to ensure that our tribes can meet those compliance measures. So that would be part of phase one. And then the management review is within each division. Our ADs would sign off on them and make sure that there's, you know, that they provide their feedback and ensure that the staff who was part of the work group is ensuring that they're meeting the needs of the population that we're serving. Then there's comments resolution. If there's any comments within the policy between the AD and the work group, those will be resolved. Once all those are resolved, then it'll go off to AD sign off, and then it'll be presented at APC. And also, I believe during this phase, also it'll also be presented at the tribal consultation meetings. And part two of that would be public comment. The tribes will have an opportunity to make comments on it, you know, provide some feedback on these policies as they're being presented. And so that's a big piece. So it's not like the tribes are kept out of anything. They're always kept in the loop of knowing what is being required. Again, I do want to emphasize that this is not a state requirement. You know, we have to really, with tribal ALTCS or ALTCS in general, has to really align with the federal compliance that they're needing us. And we're just implementing these compliance measures from the state level. So phase 6 of that is then publishing. Once everyone agrees, we can do this, we got it, then it'll be published, which is most of these cases with the policies that you'll see within the next slide. You'll see some of these policies will go into effect October 1st of 2024. So next slide. I do also want to mention that within the previous slides, our medical director, our medical team is also reviewing these policies. So you don't have to go back, Sony, just keep it there. So they do partake in some of these policy reviews to ensure, you know, that they allow to put their insight or you know, their knowledge into some of these policies that are going to be implemented. Our legal team is also part of these policies, just to ensure that they're advocating, you know, for the members and for, you know, ensuring that these health plans are in compliance and is it doable. So there's a lot of subject matter experts that are all part of this policy revision, or if they're creating a new policy, it's the same thing. It goes through the same process. So currently we have these policies open. A lot of these policy have just opened the end of January. And some of these policies, there's little to no revision. The biggest revision that we had to do was a couple of years ago when we had to implement the person-centered planning. So right now, what we're doing with Chapter 1600s is, since those revisions were already updated, there's little things that need to be updated, maybe rewording, just to provide more clarity of what is required within the policy. So some of these policies will just, 1600s are kind of just going through really fast. The policy 1620, you'll see on 1620-L, where we've already reviewed the case file documentation. We just completed that. So our team is part of that too, the tribal ALTCS team, the leadership team, and sometimes we do include the coordinators in these work group of revising or reviewing some of these policies. So that takes a big chunk of their time within the first 6 months after the new year, the new calendar year. So please keep that in mind. But right now, like I said, we've already went ahead and completed internally. We reviewed all of 1620-L, and the next ones, we just kind of go down the line and continue to review until it goes to the AD sign off, and then it goes to the tribal consultation or contractor meetings, and then it'll go to publishing. So right now, if you, like I've mentioned before last year, if you go back into any of these policies right here, and you feel, I know home health is one of the biggest ones for one of the tribes, and they're very strong advocate when it comes to home health. They speak up a lot regarding home health. And so in those cases, we do really, you know, recommend and suggest those changes within the within the policy revision when it's opened. I do want to give everyone a heads up too that there is there has been some revision made to the PPA where there's a provider participation agreement. When an access provider does become an access registered provider, they cannot refuse services to the fee-for-service programs. This includes AIHP, THP, and tribal ALTCS. So if you come across a provider that says, I'm sorry, I'm not able to provide services because we're not contracted with you, or if they say we don't service American Indian population or your health plan, please let them know. We will share the FAQ. I believe there was an FAQ for it. We'll share that with you, and also we'll be there to kind of advocate for you too if you need us to kind of intervene and say, hey, you do have to service these members. What is the reason why you're not servicing the member? Now, if it was because of they have limited providers that can go out there, that's a justifiable reason that they can't. But if they just outright say, we don't service your fee-for-service member, or we don't service your health plan, then they need to be referred over to us, or we can help out to support to let the tribe know that here's the information you can share with them. But more than likely, it'll probably be better just to give them our contact information, and then we can provide that education to them. So again, these policies are open to they have a responsibility in that area too when it comes to provider and being part of that coordination of care. So if you have any questions, concern, you can always send me an email regarding these policies and what you see that needs to be changed. But please keep in mind, we have to make sure that they are in compliance. Each program has to be in compliance with the federal requirements. It's not because we don't want to do it, because we don't have the bandwidth to do it. That's not a reasonable excuse, because these members are they do need these services. The services need to be coordinated, and there's no other health plan within the GSA within the tribal communities. So in order to understand that these providers can understand this, and also on the case management side, we do have to really reiterate to them that these are federal requirements, and we need to make sure that our members are receiving services in our communities. Next slide. Oh, I think that last little snip was for, it's just basically what I had said. They have to align with the federal and state regulations and agency manuals. If there's any agencies out there, whether it's a health plan agency or provider agency, these policies do apply to them, and it also is applicable to the tribal ALTCS IGA. In the agreement, it does state that the case management will be followed as it is written in the AMPM policy 1600. So please keep that in mind, and let your case managers know that this is a necessity. We do need to make sure that we're aligning with the policy. Okay, next slide. I'll have time for questions at the end. So I'm just going to go into my next slide. Then for tribal ALTCS, the metrics that we have annually, we have a thing called operational snapshot meetings, where within our division, we have to provide a narrative of what is going on with our population and how we have seen our population either growing or services that were being rendered. Anything that we do with tribal ALTCS, it is being tracked, it is being monitored. They also monitor our population. This is just a summary of all the tribes. It's not just a specific tribe. So we do have to present on that. We do have data that is drilled down to the tribal, and where we have seen over the years of what tribe has a number of members within their program, And then as they're decreasing or increasing, we can kind of justify what's going on. So you can see that in 2022, we were still kind of in the pandemic. But if we went back to like 2000, the numbers were a little bit higher, and it just kind of goes and grows and decrease and increase. We had more all the way up to 2019, and then 2020 during the public health emergency, our numbers went down, but we only track it for 3 years at a time. So this is 3 years of data. In 2022, we had a total of 2,149 members. Prior to that, I believe it was about 24. We used to be at 26, and slowly our numbers started to go down. But in 2022, we had 2,149 members enroll with the Tribal Long-Term Care Program. And as you can see, our numbers continue to decline. But then it declined in 2023, but now we're going back. Well, we kind of went back down, but we're slowly starting to go back up again. So we'll see that, you know, in the future, we'll see how our numbers look. And then also, I do want you to kind of direct your attention to the blue bar side. The blue bar really does present the home and members receiving services in the home. As you can see, that really has always been steady. Members receiving services in the home. We really encourage that, especially with our tribal population. We really want to encourage that because, you know, many of us know, working in the tribal communities, being a part and being a member of those tribal communities, we also know how our elderlies are. They want to stay home as long as they can. You know, they don't want to be put in a skilled nursing facility. They don't want to be put in an assisted living facility. They really want to stay in the home. And that's where the case manager's job comes into play. They are the one that, you know, hears the members out. It is members' choice. You can't force a member. If a member does not want to go to a skilled nursing facility, but they have, you know, wound care that really needs to be attended by a skilled nursing facility can provide. If you don't have a skilled nursing that can come out and do home services, those are the discussions that you really need to have with the member, and you know, allowing them and educating them and providing those services to them. That's really important. And I do always like to see this because I always emphasize that within our tribal communities, we encourage our, you know, the members in the community, family, to be supportive of the member, to ensure that we continue to provide those services in the home if it is available. If not, then, you know, maybe the member can be placed in a skilled nursing facility temporarily. But because these skilled nursing facility reviews are 6 months, doesn't mean you just place the member and forget about them, especially if they're really wanting to go home. Monitor that service that they're getting in the skilled nursing facility and continue to collaborate with them, because usually when we put members in a skilled nursing facility, they start to decline because they miss home. They want to be part of the, you know, they want to be in the community. They want to be able to see their children, because sometimes we have to send them all the way to Phoenix to get these services, and it could be hard on the family for them to come down. So those conversations really need to be happening at the case management level. Next slide. And here is the authorization. This is what we also present on. We do monitor how many faxes that are coming in for PA requests. We also monitor how many duplicates we're receiving, how many missing information we're receiving. Last year, we had quite a bit of multiple members that we were receiving in one fax that was coming into us. That was what we were had reported back to our leadership in our annual meeting. This year, you know, I'm just really glad to present to them to say, we've educated, we provided support to the tribal ALTCS. There was no multiple member faxes that came in for this year, which is really good news, because that was one of the things I think case managers were not pausing in between faxes, that it was causing a when a fax came in, it would have multiple members on that fax. So our imaging team was having a hard time separating them to the point where they couldn't separate it. So that's no longer an issue, but we are still having issues with the duplicates that are coming in. We're still getting faxes that are coming in that's missing information. And so the case manager would then submit another one, and it causes that duplicate faxes that are coming in. But I would say that probably about 89% of those issues that you see here, duplicate or missing information, is related to some fax issues that we've been having. And when your case managers are submitting documents over 15 pages, somehow it gets cut off or something happens to the fax. So there's other avenues that we're working with individual tribes, individual offices. We're kind of working on the back end to address those issues. But I do like to report this to my leadership because of the fact that this is an ongoing issue. This is not an issue that just happened this year, last year. It's been going on for a very long time. And I need them to see this because they really need to assist us and help us to address this, because we're delaying services when we're running into issues where tribal case managers are trying to submit faxes. So currently my team and I have been working with a team internally. We do have imaging team has been really heavily involved, and part of that process is when a case manager is submitting a PA request, and if they get some sort of error, they need to submit a ticket right away to let us know, hey, Access, I'm having an issue with this, and get a ticket number. As soon as they get the ticket number, it doesn't take that long. Once you go in there, create a ticket, it doesn't take that long for you to get a ticket number. When you get a ticket number, they can then email in the requests, because those ticket numbers is helping us to push it to say we have a problem. But if we're just verbally saying that, they need proof. And they're starting to see the proof now because of all the errors that are coming in. But as you're sending, then you can send your PA requests by email. Because there are only 2 coordinators. Please understand that too. I only have 2 coordinators. I have 1 specialist. And those are the only 3 people that go in to pull these documents. And we oversee all of the tribes, and you just seen the population that we service also. So we get a lot of PA requests. So faxing is the most feasible way currently. In the future, we are looking at electronic submission. We're waiting on that. We're waiting on, there is the electronic submission part. We're working on it with our ISD team and our imaging team. And then also in the near future, part of the ARPA funding, they had recommended that we look at our PMMIS system again. And that's where I have advocated to say, is there a way the new system will allow the case managers to upload the documents into the system versus having it to be faxed or emailed in, because that will just make it streamline it even more. But that part of the project is still in the beginning phase, so it might take a couple of years for that to happen slowly, but I'm hoping that that would work out in the future. That's been an ongoing discussion that we have, but currently, please bear with us. Your tickets does help us out to say they are still having issues. This is a big problem. It's delaying services. We really need to fix this. So your tickets are actually, starting to get people's attention. So if you have to email it, let us know this is a ticket number. I've already submitted the problem. Here's the email. And I think someone has a presentation later on regarding PA process. So how they would want it to look. So I don't want to touch up on that, but they'll have that in there. If you choose to email it due to some technical difficulties you're having, then they'll tell you how that needs to be done to be submitted via email. So we're making progress. We're making a little bit of progress there. Next slide. Okay, so these are the prior authorization I was talking about. This is all, if you look at it from the perspective of population and authorizations, you look at those two and you kind of compare it. For the PA authorization count, we've developed this report back in 2020. I believe we put that into effect. We drill down the PAs to the type of requests we're getting, how many we're getting, how many the nurses are getting, how many the coordinators are receiving. So you'll see we've captured only 6 months in state fiscal year 2022, because that's when we implemented this new data. The data that we're tracking now, it's automatically captured as you all are submitting the faxes. They're automatically being tracked here. Not the ones that are duplicates, not the ones that have errors, but it's only for the ones that actually have been processed by my team. So you can see the nurse gets quite a bit of PA requests. And for some of you who have been here for a very long time, been part of these meetings, know we only have one tribal ALTCS nurse. We don't have two, we don't have three, we have one. And that tribal ALTCS nurse covers all of the long-term care services. So if for specialty rates, any specialty rates that come in, she covers all of those. So please keep in mind that when you submit a PA request, they have at least 14 days to review these PA requests. And so right now you can see how the data looks. Next year, we should have a full year of data for 2023, 2024, and you'll see the 6 months from July to January. So you can see in SFY 2022, in January, we had more PA requests for a nursing facility or skilled nursing needs. And then in January 2024, we have a little bit less requests that we received. And that could only be because you've seen in the previous slide that I had, there's more members in a home and community-based services. It's always more members are receiving services in a home and community basis. So you'll see that the nurses, PAs would kind of go down. And then also on the coordinator side, the coordinators do receive certain requests, not just PA, but sometimes other requests that they receive, we monitor them too. So you'll see that the numbers, we didn't get as much this year. And I think it's because we're slowly starting to work with the case managers, work with the programs, and providing that additional education does help out too, to where they know how to coordinate services, what to coordinate at their level. We used to receive some requests that we don't have to authorize at the state level, that they can authorize in the system. So these are just requests that we receive here at Access, and my team has to review and make sure that they're processing these within the appropriate time frame. Next slide. And this is our own internal turnaround time. The policy requirements is that we have 14 days in our fee-for-service manual. Also, it does outline we have 14 days to review a PA request that we receive, but my team has been doing really good since we've been monitoring these very closely. There's a turnaround time when we receive your faxes or when we receive your PA requests. When they're faxed, it's easier because they have all the documents downloaded, so they can start working on it right away. When it's email, they have to upload it into another system in order for them to start working it. So it's an electronic filing system. So we have gone down though. I mean, we've gone up from last year for only 6 months data that we have here. We have kind of gone up in 2024 by 7 days. And that was because there has been a lot of issues with the faxes from one of the tribes. And we've been really trying to do our due diligence, along with not having a specialist and not having a nurse. We just hired for that position, for those two positions. So that could have slightly increased our 6-day turnaround for state fiscal year 2023. And I hope it doesn't go up even further, but right now we are at 7 days is our average turnaround time. Okay, and here is also a summary of the cost for long-term care services. And I just wanted to kind of give you an idea of how it looks across the board for all tribal ALTCS programs. And because many of our members are in an HCBS setting, we do always have that higher dollar amount that we spend, which this tells me that the case managers are, you've seen in the previous slide, the skilled nursing facility went down and now members are receiving services in the home. So that means that services in the home, that these are all the services that a member receives in the home. If you documented it on CA 165 and they've been paid out, you will also see it here, along with also acute care services and other services that this member receives. They'll also be captured in this data. So just please keep in mind that our numbers are going up for HCBS services, and that's a good thing because we know that members are receiving these, a lot of our members are receiving services in the home. Then you have the skilled nursing facility numbers that even though the number is up, and I'm thinking the level of care is what causes these the dollar amounts to go up, and which is also telling me that when the member is really needing that higher level of care and the cost is more, and even though we have a smaller population in a SNF, the numbers are going up, and that is only because that you all are trying to coordinate to ensure that you're not going to place these members unless they really need that skilled nursing need. So that's the numbers there. And then the other ones are alternative settings, HCBS alternative setting, whether they're in an assisted living facility, or I think we have one that's in a group home that will be considered part of the alternative setting. Next slide, I think that's it. Thank you so much, everyone. Did I go over my time? I don't want to go over my time and keep chatting and keep saying stuff. So I do appreciate everyone. If you have a specific question you want to ask me, you can always email me and ask me questions about the presentation, or if you have any concerns, or if you have any ideas, like we're in those opening phase of the policy. If you have any recommendations, say, hey, Rachel, can you, please consider this. We're having this challenge since this policy is going to be open. We don't want to wait till public comment to say something. We want to see if you can advocate for us too, because this is the challenge that we're having and this is what we would like it to look like. We do understand the requirements that need to be met, but please do so if you need me to do so. That is it for my slide if no one has any questions.
Rachel, there's questions in the chat.
Oh, I don't see that. Let me see.
Starting with Christina.
Okay. Okay, we'll start with the White Mountain Tribal ALTCS. We do get the fax confirmation, but no response from Access. Okay, they are going to cover this. This is the concern that I also had too, that any faxes that we receive, they are going to be going back to that previous process that we had, and we haven't had a specialist for since I believe October or November, beginning November. So that specialist was able to go in and document, we received your fax. We're going to go back to that to ensure that you know what is going on. So it'll be the case manager that would need to be looking at CA 165 to see once you fax in your document within 24 hours, there should be an updated comment in there to state that we did receive your fax. Okay, F3 notes. Oh, that's the comment notes. Yeah, they'll definitely make sure a response would be helpful to prevent duplication. Okay, yes, that you are correct, Janelle. By putting those comments in the comment screens will really help out. I believe that's it, right? Just remind your case managers to look at their comment screens 24 hours after they submit the PA request, because somebody should have been able to, wait, let me take that back. I was told imaging has 3 days to upload it into put it into our queue. But I would still say after 24 hours, start checking it. And someone should have updated it. Give us at least 3 days to update the comments once you send it in. But we do have 14 days from the day that you submitted that PA request for us to process that request. All right. Well, thank you so much. Very, very quiet audience today.
Okay, next up is Bandana and Amber.
Good morning, everyone. Me and Amber will be going over the weekly reports today. Next slide, please. All the supervisors are aware we will no longer require a response on the weekly reports. Case managers will need to communicate with us by placing our comments in PMMIS that addresses the specific issue and the dates on the weekly reports. Placing comments in PMMI is extremely important and helpful for us because it lets us know what is going on with the member. Next slide. Here are some really great examples of the comments that the case managers entered on the CA-165 screen. For the next review, case manager entered the date, how many times they attempted to contact the member or family. Case manager also entered the date when they were able to complete the review. Here is one example of member who was deceased. Case manager entered the date when they were informed when the member passed away. Case manager entered the location of the DOD and also closed the case on CA-161 and CA-165 screen with members DOD. Next slide. Here's another good example of member who was hospitalized. Case manager entered the date and the time when they were notified when the member was hospitalized. When member got discharged from the hospital, case manager did enter which they completed the review, and also in the comments, case manager did let us know how the member is doing. Next slide, please.
Okay, and here is some examples for member-specific comments. This is what we're looking for when reviewing comments of a member that's been on one or more of the reports, overdue. Next. And here are some good examples of loss of contact. Loss of contact and EMCR made several attempts. There's one that says DCM made multiple attempts to reach out to member both by phone call and by text. Texts were sent. This really details the multiple attempts made by the case manager along with supporting the initiation of a loss of contact letter. Next. And here's some good examples of IFS, which were entered by the case managers at each review, stating that the member prefers informal support instead of paid support. These are very helpful when a member shows up on one or more of the reports. Next. And it's our hope that with this new process, it'll reduce the redundancy of the weekly reports and enhance an ongoing communication regarding the members we serve. Going forward, the only time you will see a comment from Access on the weekly reports are for the following reasons. For example, the overdue report, a member's on the report for 30 days or more, and there's no comment in PMMIS. For the no service line, this would be like when a member has been on the report for 2 weeks or more with no services entered in PMMIS nor comments. The 029018 report, this would be when a member has been on the report for 2 weeks or more, or when the residency code does not align with the service line, and there are no comments in PMMIS. The CES reports, only after the member has been on the report for over 30 days and requiring a current CES packet or has a past due CES packet of 80% or more. This could be due to changes with the HCBS coordinated by the CM, if the member's income changes, or when rates are updated annually. Next. Bandana and I are pleased to be able to offer refresher training starting March 1st to your case managers. We are available to provide these trainings on a one-to-one basis, small group, or by office. If interested, we ask that you send us an email to the Tribal ALTCS general mailbox with the training topics such as submitting an open line request, ALF calculation, CES, maybe even a case-specific situation that they might be struggling with. Just to name a few, if you could provide the name of the interested case managers, we will then reach out and schedule with them. Thank you. Any questions?
Okay, they do have a comment in here. Do you have an example of what you would want to see in F3 for post-discharge notes? Bandana and Amber. So if a member's been hospitalized and you are telling us that the member's been discharged from the hospital, that would actually be, we don't have an example of that to share with you, but a good example would be saying on 1/1 or say on January 10th, the member was hospitalized and the member was discharged on January 12th and returned home or to the SNF. And as you all know, having gone through the audit, is that policy does state that anytime a member is hospitalized, a new review must be completed within 10 business days if the member is in a HCBS setting. The difference is if a member is in a SNF, if they were in a SNF, went to the hospital, go back to the same SNF, then a new PCSP is not required. However, if they're in a SNF, go to a hospital and go to a new SNF, then a one would be required within 10 business days. But if a member's in an HCBS setting, whether in an ALF or at home, that is required 10 business days after discharge. Does that answer your question, Joni? Okay. Thank you.
Christine has a question.
It's a long question, so I didn't put it in the chat box. So we had 2 members that were enrolled into ALTCS, but when we went to check up on the members, the placement that they were in was not access certified, and they didn't have a provider ID. So what do we do in that situation? What do we put down on CA 161 and F3 if CA 161 is not taking the placement as acute care or uncertified placement until we find something for that member?
So this member enrolled on acute care only, is that what you're saying?
Yeah, we had 2 members who were enrolled into ALTCS, and the assisted living facility where they were at didn't have an access provider ID number.
Okay. Yeah, why don't you, in that instance, document, you definitely should document on the CA 165 screen that they do not have, you're having to put in that 029108 because they do not have, but then contact us, send us an email to that general mailbox so that we can check into it and find out what's going on. Okay. Sometimes it could be that is this a member at home, did you say?
An assisted living facility?
Assisted living, okay. So it's, yeah, so then you would contact us. Maybe there's something that we can do to contact eligibility. Maybe they've been disenrolled or or didn't re-enroll correctly or whatever the case may be, but we can elevate that and hopefully assist to get those back up and running quickly. So giving us a quick heads up will help.
Okay, thank
Go
you.
ahead, Rachel.
So, Christina, in that particular case, we need to know right away when
Yes.
when you have an access, when you have a provider that is not an access registered provider, especially with the things that have been going on with behavioral health residential facilities or behavioral health facilities in general. We really do need to know because our members should be placed in an access registered provider. By being an access registered provider, they are actually agreeing to be part of and participate as a provider to ensure that they're following our compliance measures. Providers do have compliance measures too that they need to follow. So if we're placing our members in a non-access registered provider, it does really start, putting up some red flags. Not
So-
unless the member was getting paid, the facility was being paid by a private payer. That's different. If there's another insurance that is paying that provider, that insurance company, just like us, Access, they would ensure that that provider is meeting their requirements in order for them to pay them. So if there is a provider that is not an Access registered provider, you really do need to find out why that member is there. So if they were AIHP members prior to them rolling on to tribal ALTCS, I'm going to have a lot of questions for AIHP too. Were you aware that this member internally, were you aware that this member was in a non-access registered provider facility? I'm going to start asking that question because if something happens to that member and we're aware that a member is in a non-access registered provider, then that it kind of falls on us. So we really do need to know. So if a member refuses to leave that facility and they say, I want to stay here, I want it, and then you need to let them know Access is not going to pay for it. And also you need to sign this managed risk agreement because this is not an Access registered provider.
Okay, I'll send you an email about that new member that we got that was in that placement. The PAS, there was inaccurate information on that too. So we had to quickly move that member from that home and place them elsewhere.
Okay, perfect. All right. Yeah, it sounds like, yeah, there are case by case issues sometimes when those things come up. So if as long as our members are in an Access registered provider, our case managers are monitoring the services that they're receiving at these provider facilities, that's great. If they're not, we need to know right away because our members should not be there because they're not going to get paid. The providers are not going to get paid.
Okay, any other questions? Okay, so we are going to take a 10-minute break. Everyone go ahead and take a 10-minute break. Well, it's 10:07. I'm sorry. Did somebody else raise their hand?
Rachel
It was
did.
just me. It was just me.
Okay.
I wanted to just do really quick before we take our break to quickly do a follow-up on this presentation here. A loss of contact, and we're a little bit different, even though the policy has it written a certain way. But we want to, this is where we come in to be a little bit more sensitive to the population that we serve as a tribal long-term care program for tribal communities. We need to understand that our members, I do know for sure some of our members have limited phone minutes on their phone. So they might have a service plan. They don't have unlimited phone minutes, so they might miss a phone call. We do also have members who don't cannot pick up receptions in a certain area. So as leadership, you need to ensure that your case managers are not just calling because that member may not even have phone service, or they might have ran out of minutes. So those things really need to be considered when we're working with our tribal members in these areas where they have these barriers. And that's where we had encouraged previously before. Maybe there is a method you all can come up with to maybe put, I know some tribes are doing that right now. They put a door hanger on there on the member's door. They go to actually see the member and put a door hanger on there, or if somebody's there, give them a message. Who did they give the message to? The member really needs to call me, and I need to schedule a review. If they're just calling and it's going to voicemail, if you're calling and and your case manager knows that they have a limited amount of minutes, that does cause a barrier. So we really need to be mindful of that and come up with a creative way to ensure that the case managers are making every effort just to try to make contact with that member, because if they're not able to contact that member in 30 days, the case manager really needs to start the submit a request to access to say that they have lost contact with this member. And those proof will show, and some case managers have even taken pictures of the door hanger and put it in the case file to show that they've made every effort. And that door hanger picture showing the day, the time that they've reached out to the member is all on there, and they left it on the door. And, so please keep that in mind when you're, trying to make contact to do the next review. The reviews are very, very important. And then also, as for no service line, if it's due to you not making contact with the member, that's justifiable because you cannot verify if that member still needs services. But if the case manager, you as leaders, have access to the screens, if you see they did a review just recently or a month ago, but you see no services on there, that's a red flag for you leaders to look at those reports and see, hey, there's no services for this member. Because if a member is not receiving services, that could cause a quality of care concern. That could cause an issue. A member that has, maybe had a stage 1 of wound and now a stage 3, and we see that you weren't authorizing services because we can see the CA 165 screen, then it becomes an issue to why are you guys not ensuring that these services are coordinated? So please keep that in mind. Your members, if you see someone that does not have services set up on if you see someone on the no service line report, and you as leaders are looking at their service plan and you don't see services, and then you go into comments and you don't see a comment, you really need to have a discussion with your case manager, because they're putting the members at risk. They're on long-term care for a reason, because they need these long-term care services. So we should not see a whole lot of members on the no service line report. That's where the collaboration and coordination needs to happen. So please keep that in mind when it comes to no service line and overdues. Those things really need to be kept in mind. That is all I wanted to say. Thank you.
Okay, thank you. All right, now we're going to go to, unless we have any other questions, we're going to go to our break. It is now 10:12. Let's come back at 10:22. Thank you, everyone. Go get your coffee or bathroom break. Hey, it is 10:22. And just so you know, Rachel did say she had a hiccup with her system, so she had to restart. So we'll just give her one more minute. So if you had to do something, you've got one extra minute. Okay, she made it back. Thank you, Rachel. We told them they had an extra minute. We're going to go ahead and give them till there. It's 10:23. Okay, we're going to go ahead and get started. Thank you, everyone, for your attention. And we'll go to the next slide. And this is one that I'm going to go over is the DME PA requests. This has been an issue that the clinical team has told us about, so we are going to review that. Also, the NEMT specialty transport, which is also a new thing for all of us. So, excuse me. All right, so I'm sorry. Let's see, did somebody raise their hand again? Go ahead.
Good morning, Ate Pene from Mount Coffee,
Hi, Casey.
Arizona.
Uh-huh.
Oh, yeah, they've been. Are we back in the meeting now?
We are
Okay.
back in the meeting, yes.
You have to present, Casey. You
Oh,
have your
yeah.
presentation ready?
I still have my Valentine attire on from yesterday.
Okay. Did you have a question for us or just?
Yeah, I do. Okay, it's in reference to kind of where we ended before the break. And there was some discussion on no service line.
Uh-huh.
So, once in a while we have a case where, let's say the review was due at the end of, let's say, like, towards the end of January, like the very part of January. I'm just throwing this scenario out because it kind of happens every once in a while. And the case manager did the visit, attempted the visits, and then they're playing phone tag with the member. Like the member says, I'll be home tomorrow. Then case manager goes back out and they're not home. And then the case manager is busy doing other visits and they're kind of going back and forth. They're trying to get a review done. And let's say it comes into the early part of February, but the case manager hasn't updated CA 165 or it's overdue, but the member is not really committing to the review. So they're kind of playing phone tag and then the home care kind of starts pressing, saying we need entry because EVV, my provider needs to log on and all that. So we've had the information from prior meetings that I guess we would punch it in and with the confirmation that services. I mean, we wouldn't update the review date, but we would put in the services for on CA 165. That's what I've been telling my case manager is go ahead, put it in for February because they're calling you, they're telling you the services is still going in, but you just haven't do the review. So leave the review date and then until you do the review, update that date. So that's kind of what I've been instructing the case managers, and some of my case managers like, no, we should be late, and I'm like, no, put it in. So just clarification on that.
So, there's a couple of risks that you're running into. Remember, we have to follow, as I said, in our policy. The policy says that the review has to happen in order for them to coordinate those services. You're basically putting them, the case manager, because the case manager is the one that's following the case. They're the one that knows what they have assessed, and they're attesting to what they put in CA 165. So say if you're unaware, because it happens every 90 days, if you're unaware that the member was hospitalized for whatever reason, and now they have, their services have to be increased. And if you're telling them, go ahead and go by what you reviewed last time, then the service unit was less, maybe 400 units. And now because of hospitalization or whatever happened, maybe something happened to the member and now they require more services. And if the member falls and they say, well, the case manager didn't even communicate with me, or the case manager didn't follow up with me, anything could be said. And when they're putting in the same units, you're basically putting them you're putting the case manager in a position where they haven't even assessed this member. They haven't done the face-to-face to determine, or haven't even had a review with the member to determine what services have changed. So I wouldn't even recommend it. I would say keep it, don't put no services in there, as long as your comments are in there stating the attempts of the contact they're making. And that's where you really have to look at the 30-day. If they're not responding, even if they're responding to you and you're leaving notification with them, when they do make the assessment, they do need to go over the managed risk agreement with them. They do need to let them know you're putting yourself at risk when you're not home, because I really do need to make these assessments in order for me to authorize your services, because I cannot authorize your services unless we do the review. So they need to understand the importance of these reviews that are happening. So if you do come across one also, you have to let the provider know, we cannot authorize these services unless we do an assessment. So and that really brings another concern to me too, is that these services are delivered in the home. So if they're not at home, you know, how are they billing for it? Because the caregiver has to be there in the home with them when they're providing these services. So based on the previous assessment, the time that these members are to be home, based on the assessment, that's the time that they should try to make the attempt. But if they're not there, when they go there, then there's going to be red flags going up for you too. These services are provided in the home. Why is the member not here? So those are some things that you can utilize. But as long as the comments in the comment screen shows they're making that attempt, they're in there, the member will continue to show up on there. But you don't have to respond once you make that comment. I would not even authorize it. And this will put the provider, you know, they would have that knowledge too, that the provider is going to have to tell the care worker, you need to be home with the member so that the tribal ALTCS case manager can do the assessment. They can't authorize these services unless the member is there for them to do the review. But the reviews should be scheduled a couple of weeks prior to those new services, because all these services have to be prior authorized, not the day of the new month, or not 10 days after the new month, unless you have a justifiable reason why you're not able to review, like the scenarios you brought up, you know. But those comments need to be in the CA 165 comment screens, and the case manager should not be authorizing the services. Because if it goes to court, something happens to that member, they're going to want to know how come you assess less than what the member needed, and you don't want to put your case managers in that position.
Okay, so now, so on CA 165, we leave it blank or put in the dummy code?
On the CA 165, you would just leave it blank. Because there's no services. You can't authorize services if you don't know.
But
It'll
your
show,
comments would be in there.
yeah, it'll continue to show up on the report. Just as long as you have your comments, you're okay.
Also, I would like to add is that oftentimes, as you guys all know, oftentimes a lot of these members have caregivers who are family and they live in the home. So they're counting, I mean, they know they're getting paid, right? And as Rachel said, contacting the home care agency calls you and says, hey, I need services entered. Well, if that's a family caregiver, they need to understand too, is that the services cannot be PA'd if we can't do a review. So just reiterating what Rachel said, and because we have a lot of family caregivers that seem to not understand that. But you guys know that much better than we do, probably, because you run into it much more often. Thank you, Casey, for those questions. That's very good. All right, so if we don't have any more, I'm going to go ahead and move forward. Okay, so as I said at the beginning, is that the clinical team has notified us that they are having issues with PA requests coming in for services in the past that, you know, maybe October, November, December, and they're just now coming in. So I was asked to talk about this today is because on the case management side, that at each review, the case manager should be reviewing with that member. What do you need? How is your DME supplies going? Are they going to last you another 3 months to the next review? Rather than having to catch it in the middle of between, if you know they're going to be, they've got 20 days left of the briefs, and you know they're going to need it before the next review. Now you know right up front, and you can document that on your PCSP as well, is that you have reviewed, you know they have this many days left. Maybe it's their insurer or whatever it is. Maybe it's oxygen, whatever it is that they have that you are PAing for them. Just tell them, you know, what do you need? Let me know so that I can get that PA'd now, because those are vital services and supplies that our members need. Also, what we have noticed is that sometimes a new prescription is required, and reviewing that, and if you know that that prescription is past the time frame of what in order to get more supplies at that review, the case manager can be talking to the or to the member and the healthcare decision maker and telling them, hey, you're going to have either see your PCP to get a new RX, either face-to-face or telehealth. The only exception, like clinical team has said, is that the initial script must contain a face-to-face with the PCP. So if it turns out that this is just a renewal, possibly this could be done by telehealth, but it will need a new prescription. So somehow or other, we got to get that prescription. It is also important that case managers submit the DME PA request timely. Again, what I said at the beginning is that these are vital services that, or supplies that our members need, and providing, or us, not us, I say that collaboratively between you guys and us and Access, is that when we have a delay, that also can put our members in a quality of care concern. Maybe, as Rachel had stated, they have, you know, if they're laying a lot, they're bedbound, and they have briefs that they have to have, and they run out and they get sores, you know, they need to be changed timely, right? So they need their supplies. So that's something that the case manager must be following up with the member to ensure that those services and deliveries are. I'm sorry, hold on just a second. Need to see if somebody, if we could hold the questions to the end, just 1 second. Let me just finish this and then I'll answer your question, okay? One really quick thing is that that the American Academy of Family Physicians, I like this quote. I just thought it was really appropriate for this, is prior authorizations create significant barriers for family physicians to deliver timely and evidence-based care to patients by delaying the start or continuation of necessary treatment, and can be inadvertently lead to negative patient outcomes, which is really correct. So, okay, Casey, go ahead.
Okay. On this one, for like incontinent supplies, I've been real busy with direct services for quite some time now, but I really if that area around the policy change is going to be revisited, maybe we can, Navajo Nation can kind of or the tribal programs can kind of look at it, because the scripts for incontinent supplies, I mean, usually it's a year script, and a lot of our clients their condition is not going to change, but in the 3-month approval that we have to go through with access is very cumbersome. I mean, and it's like every 3 months we have to go through the process, and it's the need is kind of ongoing, and but I think that's where a policy change really needs to happen, is that it needs to better serve our clients. The 3-month period really needs to be changed. Just my comment.
Go ahead, Rachel.
That's a really good one. A good statement, Casey, because that is a continued issue that is being sent over to Access, not only from the long-term care program, but also with another program that we oversee. So every case is a case-by-case situation. It does have to be reviewed according to our federal guidelines. It has to be reviewed every 90 days. But there are exceptions that can be made. And that is probably where you can actually work with the clinical team to do work out something with the clinical team on the tribal ALTCS side. So not every case is going to be, if we just went ahead and authorize it for the whole annual period of that script, we're running into fraud, waste, and abuse. We really, that's where you all are the gatekeepers. You have to monitor it and make sure, is this something that needs to continue to happen for this member? Is it temporary? The condition, more about the member. So that's something that we do take into consideration on a case-by-case issue, but we typically, with all health plans, we do not authorize those for a whole year of that script. We have to continue to monitor it, and someone has to monitor it. Just to make sure that, is it still medically necessary? Is it being used appropriately? Are there there's providers out there that can also commit fraud, waste, fraud and abuse. So those things, the only way it can be monitored is during that 90-day review, and that 90-day review of that service that is being provided. But everything is a case by case. So not everyone has the same medical condition. So that's something where you would need to work with our clinical team and determine which ones can we review, every 6 months, and which ones can we review every 90 days. How can we work this out? And she'll have some good answers for you, because we do really have to look at it from that perspective, where when it's becoming a barrier, what exceptions can we make? So those exceptions we can make internally, but we can't do that for everyone.
Thank you, Rachel. And I see Vanessa did put a comment out there, and if everyone can see that, regarding face-to-face encounter requirements, and that that additional face-to-face encounters is only required if a new medical equipment, supply, or appliance is needed. I'm sorry, I've got little things that keep coming up. Renewals, repairs, and the need for ancillary equipment do not require a face-to-face encounter. The face-to-face encounter may occur through telehealth. So there are exceptions. If you're not sure, it is in policy, and Vanessa can help you with that if you have, or asking questions, but you should know the policy regarding this. Okay, thank you. All right, so if no more questions on that, I'll continue on. Yes, thank you. All right, next. So as a reminder, Access has 14 calendar days, and I know Rachel touched on this earlier, to review and process any submitted PA requests. When we're fully staffed, last year we lost a coordinator, which put us behind on the coordination side, case management coordination side. We lost the tribal ALTCS specialist, and we lost the tribal ALTCS nurse. We are fully staffed again, but it takes a while to train. So that calendar days may go down, but according to policy, we do have 14 calendar days to review and process. So we really need you to try to understand our position, but we also understand yours too. So unless it's an urgent or emergent request as outlined in Access AMPM policy 1620D, and failing to coordinate services prior to services being rendered is not considered an emergent or urgent request. Just so that we're clear on that. All right, and we also want to talk about the NEMT specialty transports, because we never really had an issue with this, but in the past 6 months, I would say we've had a total of 4 transports that have happened, specialty transports that are required, and because it requires a round trip and specialty cost, this is something that has to be sent to Access. So what we want to, to reiterate with you guys is the case managers, your members, and you're familiar with your members' medical conditions, and when they have medical treatments or appointments. And if a member needs stretcher transport, which is most often that we've seen these specialty NEMT specialty transports, the case manager should be networking within their community and be proactive, reaching out to NEMT providers, etc., just trying to find out in advance who can do this. Case managers need to notify Access at least a week, a minimum of a week, and preferably 2 weeks in advance of the medical appointment. And the reason for this is that these NEMT special transports, they require DFSM leadership approval, and they also require the medical director approval here at Access. So therefore, it does take extra time, and we need to allow them to thoroughly review the documentation that's been provided to ensure that it is medically necessary. Our medical director is very knowledgeable, and he is, and our leadership, they're very responsive, but they're very busy too. So we just need to have a little more extra time if you guys can. So if the only option is an ambulance transport, Access also needs to know, and we learn this by trial and error, which we learn a lot of things that way, is if it is ALS or advanced life support, or BLS, basic life support, as the cost can be significantly higher for the ALS versus BLS. And keep in mind, Access is about being cost effective. So depending on the location, somehow I lost some of my stuff, but depending on the location of the member, whether it's rural or urban setting, access may require the case manager reach out to 10 to 20 NEMT transportation companies. They need to be called, and then we need to know the reason that they cannot provide that documentation or that transportation, and that needs to be documented. And here's a quick sample of some that were provided to us, and a good example, the name, they even provided the phone number, and they do not have a stretcher transport. There was quite a number of them, but this is just a couple. I wanted to just take a snapshot of that. That's a good example, as they don't have stretcher transport. So, and the case managers must provide to access a written description of why the member requires specialty transport, i.e. such as a stretcher vehicle. Provide the member's medical condition. That's really important. What's going on with member? What's their medical condition? What is the appointment for? And then keep in mind, the access does not reimburse NEMT companies for overnight hotels for the drivers. So if it requires an overnight stay, we do not provide that hotel reimbursement for the driver. Also, NEMT, the case managers must obtain, so this is what needs to be submitted to access if you need a specialty transport, is the case manager, if at all possible, really needs to obtain 2 quotes from providers. And on that provider's letterhead, and here's a sample of the letterhead of one of them, that provides their name, their address, different information about that. So in addition, that quote should have the member's name on it, the member's access ID on it, the member's age and their date of birth. It must have the current location or the member's location, whether they're at home, ALF, or whatever, SNF, wherever they're at, and the destination address of where that medical appointment is. Must provide the medical provider name and address, the type of transport, and in this example was a stretcher vehicle, the reason for the transport, the member's condition and medical appointment, the CPT codes to be utilized, and the cost for each trip, meaning that if it's a round trip, then it would need to have, here's the first part of this, the CPT code here for the transport, the CPT code for the mileage, the cost, and then the combined. And then on the return, and then the total cost that it would be to access for that. The NEMT provider name and the NEM provider PID number. That's really important as well. And here's a couple other snapshots of an example that was provided to us of the transport that was happening and what was going on. And the snapshot of what was provided to us is that this was a follow-up to a medical procedure that had happened, and there was much more information provided, but that was really excellent information for our medical director. And he was able to say that is medically necessary. We need to get this member transported. Those are really important things. The more information, you may think it's too much, more information is better than not enough. Okay, any questions regarding any of those that I just covered? Rachel.
If no one has any questions, I do want to just give everyone here in the meeting some insight related to Sony's presentation. Not only do we do the tribal ALTCS case management audits, which is we go out to the, during the operational reviews, we go and do the audits. Internally, CMS does do a perm audit. There is a perm audit and other audits that are happening with all the claims that were paid out to providers, services that were rendered to members. They also do an internal audit based on services being provided through these programs. So currently there's a perm audit going on within Access, and I was asked questions related to some services that were provided to members in a couple of different facilities. And the perm audit team, which actually works with CMS, informed the perm audit team that we are trying to obtain medical documentation from a couple of facilities that are in the tribal community, and they are not responding. They are not providing documentation back to us to ensure that services are meeting these compliance measures. And if it continues, that they are going to not pay these facilities until they provide these medical documentation to the requests on the CMS letters. All of these providers receive letters from CMS stating we need your medical documentation. So if they are not able to obtain it, which is the reason why the perm audit team reached out to my team, is that can you obtain this just so we don't hinder the payment to the providers? Where can we obtain these records at? Because they're not uploaded into our system like the AHP side. They authorize everything so we can provide that to the perm audit team. I said, no, these services, if they're a lower level of care and does not need any requests that would go to Access for any of these lower level care, there's transportation providers that are less than 100 miles and any other services that are provided at the case management level. I said, we can obtain that through the case manager. So at any time with whatever audit is going on, Access could request these documentation. So please keep that in mind, that it's really important that, you know, if it's not documented, it never happened. You need to ensure that whoever your case manager is, it's, you know, make sure they're documenting it in the case file. In the event that somebody asks for it, they have it available and ready for that particular services. So I might have to be reaching out to a couple of you regarding some of the non-response that we're getting from providers that your case managers are coordinating services with. And I am hoping, crossing my fingers, that you have documentation in the case file for the requests that CMS has. So just keep that in mind. So it's really good to make sure that you all are documenting it. As for the transportation services, our transportation team, this whole process that we have, it's a learning curve for my team. We have a specific transportation team that does it, that used to do this for years. They're now taking over to kind of help with the administration part of it, you know, of gathering the documentation, gathering the information so they can send it over for it to be reviewed by our medical director and our AD. So that's very, very important, because the more information they have they're able to say, okay, there is no other transportation that would be feasible for this member. They have a very complex medical condition. It does require a specific type of transport, but it's going to cost a lot of money. We have to justify that, because when we're being audited, we have to have those documentation. So please keep that in mind. Our transportation team also does verify, because of all the fraud, waste, and abuse that was happening with transportation years ago. They now have to verify. If you say it's from this location to this location, they're going to go and do a GPS search of how many miles are from that location to this location, to ensure that services are being provided appropriately according to the requests that we're receiving. So please keep that in mind. Yes, Casey.
Oh, the term you're using, perm, is that can you Is that for home health or?
It's they all services. It depends on what CMS, just like we do to you guys, right? We give you a random list of members and we say we want to see these case files and we want to know what services were, we want to see, make sure coordination of care is happening.
Yeah.
As for when CMS comes to access and say for specific procedures that has happened within X amount of time, we want to pull all of these we want to pull these members and we want to see all the medical documentation of why this service was approved and paid for by Access. We want to see that it was medically necessary and that it was cost effective. So they will ask our internal Access team to obtain those medical documentation. But sometimes there are, like, on anything that is for this is really particularly what they're doing right now, I believe, is a SNF and certain assistant living facilities that came up. And another one was transportation that came up. So I will be reaching out to a couple of you all to ask for medical documentation your case managers may have in their case file, which is 6 months review for the SNF facility. So there's a couple of them that have came up. So I'll be reaching out to you all to figure out, does your case manager have the medical documentation, the reviews of what they have conducted on their last assessment, because they're having a hard time obtaining it from the provider. So I said, we have it, but it would be at the case management level. If it's a lower level of care, the 0190 all the way to the 0193, I said they would have it. Anything above that, we would have it, and we can provide that to the audit team internally. So like I said, there's always somebody wanting to review why services are being rendered. Somebody's going to come in and audit the case. It's not just us coming in to audit during the operational review, but there's always audit for all services: acute, transportation, long-term care services, behavioral health services. It just all depends on what CMS wants to look at when it comes to services that are rendered.
Thank you, Rachel. Vanessa, we do have a comment in there, and I'll let you expound on this, but it's from Bronwyn at White Mountain. So when a customer's 12-month DME incontinence script expires, the customer does not need to have a face-to-face consult with their PCP for another year of supplies. It's a question. My members currently go and meet with their PCP for new DME script to continue DME supply for the new year.
So the face-to-face wouldn't be required from us for prior authorization. It may be something that's required from the PCP to renew the script. That would be up to the PCP or the clinician that is following the member for their DME incontinence supplies. Typically, I do see that they do have to go see the physician so that the physician can write the script, but we wouldn't require a new face-to-face for the prior authorization unless there's a change. So if the member does go to their PCP for their script renewal, the only time we would need the face-to-face is if they're making a change in the quantities that they're receiving. Maybe there's a change in the member's condition that, they now have the need to change the supplies or the brands that they're receiving. But they would more than likely still need to go see their PCP to get that script renewal. We just wouldn't need it here for PA unless there is something else that's being requested.
Thank you, Vanessa. So we still need a renewal, but not necessarily face-to-face. Okay, so we're going to go next if we have no more questions. Some good questions, guys. We really appreciate you speaking up. Okay. So next I'm going to turn it over to Vanessa.
Okay, so I will be going over the AAC prior authorization requests for the augmentative communication devices, home modification release forms and repairs, PA requests, faxes, and CA-165 for prior authorization updates. So for the AAC authorizations, these include the augmentative and alternative communication devices. We have seen some of these come in as far as requesting evaluations or looking to get evaluations done. AACs come in different types. There's different types of AACs. They have low-tech communication devices, which uh, don't require extra equipment. It's just sometimes called unaided communication. There's low-tech communication systems. Low-tech communication systems do not need power to function. And then there's the high-tech communication systems, which do require batteries or main power, and those are more of like the technical computer type systems. And there's just visuals as to what the AAC devices look like and just what other types they come in. So next slide. For the AAC process, you'll get a PCP who writes a script for an AAC eval. Those evals would go to the tribal case managers to submit for an AAC eval. I did list the codes that those usually refer to. That's the 92607 and the 92608. A professional speech therapist or assistive technology professional will evaluate the member with their speech and language and identify which AAC device would meet the member's needs. That evaluation will then go to the case manager and they would submit it to the AAC DME provider. The DME provider will then render the services to the member, and the AAC agency or therapy service that did the eval can also provide the AAC training, and that's the 92609. There are a couple questions to enlarge the slide because they can't read it clearly. I don't know if you can enlarge it anymore.
No, it's not letting me.
We do have the AAC handout.
Oh, wait, there it did it. There it did
We'd
it.
be able to share that with the case managers. Then
Sorry,
for
let me. Yes. It's just doing the little thing over here. It won't actually, it kind of did, but then it didn't. So you may have to, when it gets out to the digital toolbox, you guys can review that and enlarge it on your side, take snapshots, whatever, to see that. Sorry about that. Okay, are you ready for me to go to the next slide?
yes. Okay, so for the AAC evaluations, the required documents are you do need a script from the PCP. The script should state evaluation for AAC, or it can say evaluation for augmentative communication device and therapy treatment. As long as it has a similar verbiage, that is all that's required for an evaluation. We also would need the face-to-face within the past 6 months. Once we get the scripts for the evaluation, those will be submitted to us here at Access to get prior authorization for the eval. And the prior authorization would be for the agency that would be providing the evaluation. For the DME request, The evaluation would show which appropriate DME device is being recommended. The PCP would agree with the evaluation and sign for a certificate of medical necessity. And then that script with the AAC eval and the provider's quote would be submitted for the DME item. Next slide. For the DME agencies that provide the DME equipment, we do currently work with PRC Satillo, and there is their point of contact, their phone number, their email, their provider ID. The next provider is Tobii Dynavox. We have the point of contacts, their phone numbers, emails, and their provider ID, as well as their website. Next slide. For the AAC agencies that provide the evaluation, there is NAU with the point of contacts, phone numbers, emails, and websites. They do have intake forms on their website and the service areas that they do provide services in, as well as Savita assisted therapy solutions, their point of contact, emails, and websites, as well as the service areas they service. Next slide. For home modification completions, we have gotten a couple of requests for the home modification warranty or repairs. When it comes to home modification completions, the contractors do a walkthrough with the members or the family members, and they sign a release form stating that the project and the work was completed and accepted. If the member and the family is not happy with the work or they're declining items requested, please educate them to express the home modification concerns prior to signing the release form and to list any requested items that the member or the family member, later declined, whether it's during the home mod or towards the end of the home mod. Maybe they decide they don't want the grab bars, or they decided they don't want part of the home mod completed. They can state it on this form, as well as if they do have any concerns with the work, the contractors there on site, so they would be able to complete any of those concerns while they are still there at the home. And this is just to ensure that the home modification project is completed to the member and access is satisfaction. This is just an example of what the home modification release forms look like. These forms are from the contractors, and they do submit them when the home mods are completed. It gives the member's name, their access ID, the home mod was completed, what date the home mod was completed, and just an area for the member to write whether they're satisfied or they have any comments for the home mod, as well as just a space for them to decline items, and their area for them to sign, as well as contractors. Next slide. For the home modification warranty and repairs, the home modification warranty repairs are based on the contractors individually. If there are any home mod warranty or repairs that are needed, if you can email the member's name, their ID number, what the reported issue for the home mod is, the date the home mod was completed, the member's address, or any pictures that are available from the member as far as what the concerns are. And then this information will be shared with the contractor so that we can schedule a repair. Next slide. For acute care services, we do get inquiries on acute care services. So this is the acute care service process. I do have the services outlined as far as what is included in the acute care service provider types. All the acute care service prior authorization requests do need to get faxed to the DFSM fax number provided. The request will be from the provider directly. The case managers should not be getting these requests. The DFSM team will look at the PA requests and enter the prior authorizations into PMIS. The provider will get a response on the provider web portal or via fax. The provider will need to log into their web portal to check the determination. The tribal ALTCS case managers will not receive any notification of the status of the acute care services. And in the event that the provider is reaching out to the tribal case manager, please get the contact information that the providers are given as far as who's giving the misinformation. Next slide. And this is just another slide regarding the acute care service request. The fax number to be given out if there is a provider that is requesting an acute care service. If a provider is directed to you by DFSM, if you can provide or request the name of the individual who is giving the misinformation, and then please advise the provider that they would need to allow 14 days to review the request. Next slide. So for tribal ALTCS members, the age of 21 years and older, I am referring you guys to 310P for incontinence briefs and supplies. We have seen an increase in quantities or over limit requests. We do need the scripts and the evidence of medical necessity. The policy does list an amount for the items in any combination unless there is evidence for the medical necessity. For members who are over 21 and older, this information is required for the quantity increases or any over limit requests, as those would be sent over to the medical director to review. The next slide is for members who are under the age of 21. We have received some requests for members who are under the age of 21. There is another policy for members who would be referred to AMPM 430. Their policy is a little different from the 310P as far as quantity limits and what's required for the members who are over the age of 3 and under the age of 21. Next slide. For receipt and imaging departments regarding the faxes, WriteFax has a 72-hour turnaround time. Please take that into account when sending faxes in. Please allow 72 hours before contacting prior authorization to check on the status of the fax. And then please refer to the service plan CA-165 for any prior authorization updates entered by the specialist. With the fax cover sheets, this is just another reminder to ensure that the prior authorization request form is completed correctly and to ensure that your requests are not misfiled. We have gotten some who are either checking prior authorization DME or they're checking multiple boxes. The requests do get filed by the scanning department, so they'll get misfiled. But just as a reminder, please ensure that the correct boxes are filled out and the form is completed correctly. Next slide. For any return faxes, please ensure you're using the updated forms. And if you are getting a return fax These are sent out from the scanning department, and you will need to resubmit if you get a returned fax response. For the prior authorization correction form, when a prior authorization correction is being requested, a prior authorization correction form should be submitted. The correction form should be completed and indicate the specific instructions as to what is being requested to have changed on the PA, whether it's the HCPCS codes, the prices, if something needs to be kept or removed. I did include the link for the form. This includes any date of service extensions. For date of service extensions, if you can request a reason or a justification for the provider as to why the extension needs to be done. As well as any changes to the prices or the HCPCS codes, if you can include the updated provider's quote. There is the links for the PA request forms, PA correction forms, as well as the medical documentation forms. Next slide. For any claims questions, I'm providing the claims contact information, their schedule and times, as well as the provider training and resources email if any providers reach out to you regarding questions on claims and provider training. And we do have new team members, so we do have a tribal ALTCS nurse. Her name is Natalie Scaley, and the tribal ALTCS specialist, Tiana So.
So welcome. We want to welcome both of these new team members, and you should be having some contact with them in the future. I'm sure you will. But thank you.
For the tribal ALTCS nursing specialist, if you have any questions or inquiries regarding prior authorization, if you can please email the tribal ALTCS general mailbox. For the subject line, if you could include the prior authorization and what the prior authorization is regarding, whether it is prior authorization SR, prior authorization DME, prior authorization ELF, or home mods. If you can include in the body of the email the member's name, their ID number, the provider's ID, or any detailed information regarding the prior authorization, this will assist us in looking up the prior authorization and assisting further. Just as a note, please don't use this email to check the status of your PA request. I am preferring that everybody goes to the CA 165 for submissions of requests on short notice. Does not constitute an urgent request. An urgent request or an expedited request can take up to 3 days to review. Requests submitted as urgent that are determined to be routine in nature will be processed in accordance with the standard review times. Any questions?
Okay. If nobody has any questions, we'll go forward. Thank you, Vanessa. Okay, now it's our time, and I have been notified by Amber and Vanessa and Bandana that we do have some winners. And those winners are Bandana and Amber. Go ahead. Can you speak, unmute yourself and
Yes, the winners are Jolie.
from San
And-
Carlos?
Yes. And Lakeisha
From Gila River?
and Frida.
From Navajo Nation. Awesome.
Yay.
So, yes, thank you all for participating. We're trying to make it a little lighthearted and help, make it a little happy sometimes, because we know it can be a lot of information. But so the three of you, we will send out some gift cards and to you, and so be watching for those probably by Monday at the latest. Okay. And I think that is it for us on this side. I'm going to go ahead and transfer this over to Rachel to do our closing remarks. It looks like we're a little early. We got done a little earlier, but I'm going to go ahead and transfer it over to Rachel now. Thank you.
Yay, we got through it. We made it through the whole thing. Good questions, good feedback, and this is your time to kind of provide some questions and concerns that you have. And it's always good to learn new things when it comes to our program. And I really love Casey's questions related to PERM. What does it mean? And we're always talking about audits. So with PERM, how it relates to access is basically CMS comes in, they're looking for payment error rate measures. They measure our payments that we make. These are for all services, not just long-term care services, but it could be acute care services, just whatever us as a plan pays out to these providers that are registered with us. So they do conduct an audit. CMS does conduct an audit on these payments. The payments are being reviewed. So at this point, we do have, like I mentioned, a couple of SNFs and assisted living facilities and a transportation company for our tribal ALTCS members that they had questions on. So in these audits that are happening, these are conducted by CMS. They do require certain information that they would need from the provider. So if we don't have it in our system here at Access, we'll be reaching out to you all to see if you have anything in your case file that you can share with us related to these providers that render services to you, especially those ones that are services related to what we went over today, like those specialty transportation services or specialty rates with skilled nursing facility or behavioral health facilities. You would have more documentation in your case file. If we don't have it if we don't approve it at our level, you would have it at your level. So we could be reaching out to you all to submit those over to us. So I just wanted to give, if you want to know more about the PERM audits, more information about it, I did put it in the chat. As all know that once we close out the meeting, it's going to get rid of this chat. So please, if you want to gain more knowledge about what PERM audit is for Access, you can always click on the website and get more information to get more insight on what a PERM audit is when it has to do with Access. So just to kind of summarize what we all have learned today, and you all now know that we do get audited too. So, just keep that in mind, that we all have a lot of responsibilities. All of our offices, we all have a lot of responsibilities, not just the case manager at your level, but also at the state level. We all have compliance measures that we have to follow. We all have regulations that we all have to follow. The policies that we have in place is pretty much clearly written out. Our previous people that were in these positions and current people that are in the positions are very familiar with the program and how it works and how the relationship is between the state and also with the tribes on how we work together. And you as leadership are the one that's helping us to ensure that our members are receiving services, that you're helping us to stay in compliance with these requirements that are set by CMS. So part of, our responsibility is ensuring that everything needs to be documented, everything needs to be coordinated for these members, services are being coordinated, educating the members, very important, letting them know, these reviews are very important. When every time they review, you must be present to do a review unless, they're meeting those, if they're in a setting that doesn't require that face-to-face, like acute care only, if they're in that those just need to be reviewed annually. But any other services that are being provided to the member, it needs to be reviewed, and we need to make sure that we're being proactive. So we have a lot of responsibilities along with caseload review, reportings that you have to send over to access the quarterly report, like the caseload ratio, the supervisory audit. Those should all be based on some of the things that we go over in our quarterly meetings. So please be mindful of that and ensure that our members are receiving, these services. As a supervisor, you're actually ensuring, when you're doing your case audit review, that you're ensuring that there's documentation in the file, that you're doing the reviews timely, that you're ensuring that members are receiving services. Those quarterly reports are very important in the event that, there's questions about it. And it also impacts your operational reviews too. So make sure that you keep that in mind as a supervisor. So it's really important that leadership attend these meetings, or your lead, if you have leads in the office, if you're not available. I know with some of the tribe supervisors do carry a caseload, and I sometimes imagine, how do they shuffle it? How do they do it? They have to be super amazing to have a caseload and then also supervise, because they have that huge responsibility of, making sure that services are being coordinated. They are the first point of contact. So I always think of those supervisors who carry a caseload. Wow, they must have some superpowers, because they travel quite distance to get things done. So kudos to those ones that carry a caseload, and ensuring that these reports are delivered back to access in a timely fashion, and making sure that members are receiving services. So we all have a lot of responsibilities, from the ground up of creating policy to implementing the services, to actually coordinating the services, doing outreach to providers, educating the member. All of those things, we all work together as a team to do it. So whenever you run into any issues or barriers, when you contact us, we try to do our best to make sure that you guys are meeting these requirements, and that we're providing the tools and resources that you need to be successful in coordinating those services. And then also that we address these challenges as we come across them, and not waiting a whole 6 months, a year before we say something. We should always be advocating for our members and trying to alleviate some of the barriers that they have in their own communities. And your case managers know their members very well. A lot of them have been with their members for a long time, so they would know what the member needs. And we've also mentioned a couple of times, if there's a PCSP that they're filling out, they can pre-fill some of those areas to kind of cut down on time, and when they do the reviews. And then if there's goals and measures that need to be met that they've documented last time, don't forget to ask those questions. How is your goals working out? Have you accomplished them? What have you done? And giving some ownership and allowing the member to have a voice, and following back up with them. And if that goal isn't working, create a new goal at the next assessment, but do document why that previous goal did not work out, because there's more updates and questions related to goals. And if they're culturally, if you're being culturally sensitive, which we know you are, it just makes more of a clear picture at the state level what each of the program is doing. So all of these things, like I said, they're all part of our policies and procedures, rules and regulations set by CMS. And we're just the middle people trying to ensure that, yes, they are following it. So not every case is we can't help you or you shouldn't be doing that. You know, if there's a lack of understanding somewhere, or if you need more education, if you need more time, Sony and the team's always available to provide that or coordinate that to ensure that you guys are getting the support that you need from Access. So I don't have anything else to present on. I do appreciate all the hard work that you all do. And just please be mindful. I only have 2 coordinators that oversee the whole entire population we showed in this presentation. They you know, authorize those services. The thing is, I also only have 1 nurse, and that makes it a bit of challenge sometimes, because Vanessa does also oversee the THP nurses. She oversees those nurses too. So she is not always available to help our tribal ALTCS nurse. So please be mindful of that we do have 14 days to turn around these requests. Internally, we just kind of set our own personal goal, and we try to meet it as much as we can. But you know, we do our best to make sure coordination of care happens, but we need your help. And part of that is through these trainings we provide. Always review it. If you forgot something or don't know it, or maybe your team member asks a question, review them, review the policy, know them so you can know quickly how to respond and be that support for your case manager, because my team might be very busy in answering those questions. And then you also internally do have a lot of subject matter experts at the case management level. There's a couple of nurses that are within the programs that's always being supportive for their team. So we very rarely hear clinical questions from those programs that have nurses. So it's a benefit to have a nurse on staff to kind of review some of these cases. And they use the nurses to their advantage. So it does help to have that too. So, but like I said, thank you so much for attending today. And we will definitely get this out to you all once we end the meeting. And if you have any other questions related to anything on the presentation, please don't hesitate to send us an email and let us know what you want us to elaborate more on. But thank you for your participation. Also, for those of you that participated, we appreciate you, and you all have a great day.
Thank you, everyone. We'll stop the recording now.